So thank you everyone for joining us for the webinar on uh, Oncology Beyond the Obvious. It gives me great pleasure to introduce our program directors, Dr. Amish Vora, medical oncologist from New Delhi, and Dr. Purvish Parikh, medical oncologist from Mumbai. So I'll hand over the mic to our program directors to start the program. Over to you, sir.
Thank you very much, Kashish and Kavina Creations. I think today is Baker's dozen for Oncology Beyond the Obvious. We crossed 12 and today is our 13th meeting. In such a short time, because of the specific direction that we have taken, it has become really popular. And we just heard Dr. Tilak uh, putting his comments on the same. So the reason is very simple, that each session, however long it may be, uh, is focused on a specific manuscript of publication. And then we have stalwarts with personal experience and insight that give us the finer points in each and every aspect of that publication. And therefore, in our local Indian context or in the SAARC region context, we are able to really, identify what is the value of that publication. We started with several landmark publications, and subsequently we even had a face-to-face meeting in Mumbai. And then we moved to, a little bit different from what we were doing earlier. And that is to, even if it's not a landmark publication, but it's something that is important from the Indian context or from the global level, we are very happy to discuss that. And I think Amish has been really right in picking up this particular manuscript for today's discussion. It is about PDL1 blockade in mismatch repair deficient locally advanced rectal cancer. And the real reason is what Amish will explain as he takes over. So I don't want to steal the thunder from him. And it is my honor and privilege to pass it on to Dr. Amish Vora, my co-director for Oncology Beyond the Obvious, to start the next part of the program for today. Over to you, Amish.
Thank you, sir. Uh, so as the process goes, we will first present few slides about the topic what we are discussing today. After that, there would be an interview, panel discussion, and then an expert opinion. So let's start with our slide presentation. Kashish, can I have my first slide? Okay. Right. Thank you so much. So the topic today is PD-1 blockade in localized rectal cancer. And I would again repeat, localized rectal cancer. Next slide, please. So this is June 2022. That is just hardly 20 days before. This publication has come in New England Journal of Medicine. And again, the title is PD-1 blockade in mismatch repair deficient locally advanced rectal cancer. Next slide, please. This is a single institute phase 2 investigator initiated trial. The planned enrollment was of 30 patients. The data presented in this article is from 16 patients because of the statistics being covered, already achieved of what they started to achieve. 12 of 16 patients have completed trial treatment, and 4 out of 16 patients have more than 1 year of follow-up. Next slide, please. So what was the treatment? Treatment was PD-1 blockade, monoclonal antibody, that is dostarlimab. This is again one immunotherapy drug. Dostarlimab, if many of you know or don't know, has already been approved in endometrial cancer and also like a blanket approval in solid tumors, like the pembrolizumab is being approved in patients with MSI high and solid tumors. Now, the inclusion criteria in the current trial of Memorial Sloan Kettering was patients who are suffering or are diagnosed from stage 2 or 3 rectal cancer, biopsy proven, and with MSI high on immunohistochemistry. All patients should be fit for chemotherapy, radiotherapy, and surgery. and they should be willing to undergo these. Next slide, please. There were two primary endpoints. One was complete clinical response sustained more than 1 year in dostarlimab alone group, or pathological complete response in patients undergoing trimodality treatment. So basically, what they had done was all the patients were started with neoadjuvant dostarlimab. If the patient achieves complete clinical response, patient was not given anything. And if the patient does not achieve complete clinical response, then patient would undergo trimodality treatment as we normally do in our day-to-day practice. The second primary endpoint was overall response rate with only neoadjuvant treatment, that is either dostarlimab alone or chemoradiotherapy minus surgery. This trial was presented in and published in NEJM for two reasons. One, the second primary endpoint was achieved, and second, the null hypothesis on which they had started this was far proven beyond utility. Next slide, please. So the response evaluation, the clinical response evaluation was digital rectal examination and endoscopy, and also biopsy of the visible tumor, MRI and PET scan. Every 6 weeks, 3 months, 6 months, and after that, every 4 months. Next slide, please. So this was the patient characteristics. As you can see, the 16 patients were enrolled as the plan is 30 patients. 62% were females and median age was 54 years. I would like to point out that we all have started seeing younger and younger patients with rectal cancer. And I think everybody would agree as the age is advancing towards younger side. 11 were white, 3 were Asian, 2 were black, and 1 was Hispanic. All were good ECOG performance status. Majority of these patients were node positive. 15 out of 16 patients were node positive. Next slide, please. 16 patients enrolled, 12 out of 16 have completed all 6 months of treatment. 100% complete clinical response. You know, everybody has read about this article and has read in media, but I have not seen this type of thing. 100% complete clinical response, median follow-up of 12 months, and not a single patient has relapsed. All 16 patients at the time of publication are alive. Next slide, please. In addition to response, I must say that the authors have thought much in detail. Many biomarkers are studied, and in the complete publication, it is there. PD-L1 expression over a period of time, tumor infiltrating lymphocytes, T and B lymphocytes, both. Very well documented biopsy report, NGS reports, and MSI reports are there in the publication. Next slide, please. There has been no approval which has been granted to dostarlimab in localized rectal cancer as of today. There is not a single guideline which have incorporated dostarlimab in localized rectal cancer. The trial is ongoing, but we are discussing this today is that are the results compelling enough for us to change our practice? Thank you so much, Kashish. With that, I would like to invite our interviewer today. Do we have Dr. Ankur?
Yes, I'm there.
Yes. Hi, Ankur.
Hi, sir. How are you?
So it is my honor to introduce Dr. Ankur Bahl. Dr. Ankur Bahl is MBBS, MD, and DM. MBBS and MD is from MAMC. He is a prodigy of MAMC. He keeps saying that all the time. He has done his DM from AIMS. After that, he was in Rajiv Gandhi Cancer Institute, followed by Max, where I met him. And now I am a friend for life for him, whether he likes it or not. After that, now he has joined in Fortis Memorial Research Institute in Gurgaon. In terms of academics, apart from a very keen clinician, Dr. Ankur Bahl has an excellent panache of publishing whatever he treats and he sees. I don't know if many of you know, he has the largest series of acute myeloid leukemia from AIMS, which he has published. And even in the private setting in Max Hospital, He has the largest data of cetuximab in head and neck cancer, which he has published. I must have presented at least 10 presentations where it's my honor to tell from Dr. Bahl et al. And you must read his cetuximab data. It is an amazing insight into what anti-EGFR does today. He was the first to start debates in oncology in NCR. I don't know whether it was first in India, but I know it was first in north of India. That much I know. And it was an amazing beginning. Apart from that, there are many other firsts for Ankur. He started live oncology tumor board, masterclass workshops, and many others. Few other things apart from academics, Dr. Ankur, when I was in Max, was very famous amongst Afghani interpreters. And many patients who used to come from Afghanistan, in the hotel where they used to stay, the interpreters used to put Ankur Bahl's photograph and they say, see, this is the doctor tomorrow you are going. And I can swear to any one of you that all the patients in last 5 years, Afghani patients I have seen, all of them carry Dr. Ankur Bahl's prescription. And why is this? Dr. Ankur, Dr. Nitesh and myself, we were in Max Hospital. Ankur has a completely different way of counseling. We all take pride in our counseling, but I have learned so many things about counseling. He can change his modus counseling operandi depending on who is in front of him. And that is something amazing. And the last but not the least, Ankur is an excellent team member. Yaro ka yaar. At 2 a.m. in the morning, if you require, call him and he'll be there. And if you ever get a chance to work with Dr. Ankur, aap band karke haan bol do, you will enjoy working with him because he's going to excel anywhere. Ped ke niche bhi khada rahega, Ankur Bahl is going to excel. Thank you, Ankur, for joining us today.
Thank you so much, Dr. Amish. I mean, it's been so generous word. And Tilak has written, "Ke dost ab rulayega kya? Dostane mein will not make us cry. It will make us happy in next 5 years." And you've been very generous to secure my future for next 10 years. Everybody is going to hire me now. Yeah. Thank you so much, Dr. Amish, Dr. Purvish, and Kavina Creations. And I think I will do justice to this interview. And let's hope a fruitful next 25 minutes.
Thank you, Ankur. So let us start with our interview. As you know, there will be first 6 or 7 rapid fire questions, and I would request you to answer them rapidly so that we can finish it on time. Stage 2, 3 rectal cancer today, how are you treating them?
So stage 2, 3 after adequate staging, and if the burden is high T3, T4 or a heavy nodal, I would not shy for a total neoadjuvant therapy. Give him 4 to 6 cycles of FOLFOX, followed by concurrent chemoradiation, and then followed by surgery. My maximum goal is to achieve what we have been seeing in other cancers, which is pathological CR, and TNT has proven to increase PFS, OS. And
so how much is the PAT CR in your clinical setting when you use TNT?
So not assessed, but yes, my thing and the literature and my experience says that 1/4 of the population, if given the right dosages, the dose dense dosages, not shying from the capecitabine dose, not shying from the even admission, the mucositis, the perineal skin reactions, we will be able to achieve 25 to 30% of PAT CRs. And if
so you do not shy away from giving the proper dose of capecitabine. I think that's the mistake where many of us take. But let's not talk about capecitabine dose, but it is good to know. If you achieve a PAT CR, Ankur, do you give adjuvant chemotherapy? Because there's a lot of debate about adjuvant setting.
Yes, even the guidelines are divided. So what we follow and what our radiation oncologist teaches us, it's a multidisciplinary tumor board. Always the pre-op clinical and radiological staging should be taken as the actual stage, and on the basis of pre-op perirectal, pararectal, the CRMs, that should decide whether we should give adjuvant chemotherapy or not. And if we get node negative T1, T2 or a T0, TIS, so then there is a role of single agent capecitabine or even surveillance. But yes, the pre-op radiological and clinical stages determine the pre-treatment determines the outcome, and I give my adjuvant treatment on the basis of pre-treatment staging.
Not based on PAT CR, but the pre-treatment staging, what you do. And it is very little different from TNT protocol which Sloan started. And I think 78 patients after TNT, those who achieved complete radiological response, they have not undergone surgery, and they are following up. But absolutely fine, because that is what we all follow. Do you do MSI in all patients,
Uh,
Ankur?
no, not in stage 2, stage 3. It was not a reflex testing from my side, although it is recommended in all colorectal. But yes, since this June 22, I am compelled in my mind to get an MSI to get that subset of patient, to at least offer them one of the treatment. And my practice and my kind of patients, and everybody sees that patient will ask one word, which is, can we take immunotherapy, can we take
Correct.
immunotherapy? It's not about giving immunotherapy, it's about discussing that
Discussing about.
IO thing with the patient, even if it is stage 2, stage 3. So I need to know more
So
if
you
it
will
comes to a
start doing
patient.
MSI in all your rectal and colorectal cancer patients.
A big
Dr.
yes.
Ankur, if the MSI, see, tomorrow you have a stage 3 rectal cancer where you have planned for TNT. And if you find that MSI is high, and you know that high MSI respond very poorly to chemotherapy, would you think that in those patients, TNT would be a deterrent and you would start straight away going towards surgery very fast, or you would not change your practice?
There is no data to support this thought. We know that those patients who have MSI high or deficient MMR, they will not respond to chemotherapy, radiotherapy. But there's a parallel data of something called as neoantigen, tumor antigen. So the literature and the experience is divided. At this point of time, MSI high, stage 3, TNT or concurrent chemoradiation followed by surgery, I would not like to change
You would
practice on the
not like
basis of
to
12
change.
patients.
Correct. I agree. No. So there was a large data where they said 7% is the response rate of TNT in MSI high colorectal cancer patients. That's why I asked that question. But I take that we do not have sufficient data to change our practice today. Dr. Ankur, as we would discuss further in this trial, and I'm very much intrigued, MSI we do by immunohistochemistry. Intact expression means no mutation, and loss of expressions means some mutation present. We do, all of us do 4 proteins. Okay. One loss of expression is MSI-L, low. 2 is MSI-high. But in my practice, I have used MSI-1 also as MSI-high, and patients have responded. And I see in this paper also the same thing was there. What do you do in your clinical practice? Do you wait for 2?
So no, as you rightly said, this is mismatch repair protein deficiency. So genome has to be sequenced, genome has to be repaired. If there's a repair deficiency, then the microsatellite instability comes. If there is a microsatellite instability, the genotype of this patient is, I would say, inflamed one, which I have used in many of my thing. And immunotherapy will work because there's a lot of PDL1, PDL2, and the binding of PDL1 to PDL2 with PDL1 from tumor lymphocyte to the cancer cells, this determines. So if I have one mismatch repair, and I would not shy to discuss with my molecular oncologist, I would like to pick up a call and discuss in detail. At times we have done IHC, at times we have done PCR. So this paper has heavily relied on IHC, and we will discuss what all biomarkers were being taken for these 12 patients. But yes, this patient emphasized on IHC, MHC testing with many other biomarkers which were being studied, which we'll discuss.
We will discuss that. My question is again unanswered, Dr. Ankur. Single loss of expression. In your clinical practice, do you take as MSI high?
No, we take at least 2 to make
You
it
take
as
at least
MSI
2.
high.
Here in this paper, it was, if you see in the table, they have taken 1, but yes, of course, they had an NGS data packed up and many other things as
And
we'll
variable,
discuss.
yes, we have.
Yeah. So my second last question, very quick, this is very heavily dependent on the trial success. We all have been treating metastatic colorectal cancer with MSI high as with immunotherapy. How many of these patients in your practice have relapsed so far?
If I recall, immunotherapy in colorectal cancer, we have
MSI high.
MSI high. We have couple of common patients as well. So as far as I remembered, 7 or 8 patients which I have given in last 2 to 3 years, they are very long responders. They have responded very well. In between, I have given them some chemotherapy, break from immunotherapy when they have progressed. I've used combination of chemotherapy, immunotherapy, And in one patient, I recall I have re-challenged immunotherapy, the different immunotherapy. So that is out of box. But yes, if I recall, if I compare with them a non-MSI stable metastatic colorectal cancer with anti-EGFR or anti-VEGF, and then for the regorafenib and second line, third line, fourth line. So they were bad patient, MSI high. I consider they were longer sustainable patient, and they have a longer OS survival as compared to on the basis of those 7-8 patients only.
Right. So, Ankur, we are running short of time, but as we discussed earlier, uh, stage 2, stage 3 colorectal cancer patients, median age of 50 or so in our practice, infertility, sexual dysfunction, urinary incontinence, and permanent colostomy, I think leads into a depression and quality of life in almost 100% of patients. You would agree on that?
Yes, I would agree with the younger population coming to us. Nobody is happy with rectal cancer. Even if you achieve a pathological CR,
Complete.
there is a
Absolutely.
taboo, there is a stigma of that stoma, that stool coming out of the anterior abdominal wall, not able to dress properly, not even to have sexual functions properly, not even to go to a party or a get together normally. So there is always a depression, more than 90% in whatever we claim, but I see depression a lot in family members and the spouses both.
Correct. Right, Ankur, we have 10 to 12 minutes precisely. Let's go to the paper now. It's a prospective phase 2 study done by Sloan Kettering, single institute IIT. Do you recall in your past, have you ever changed your practice based on this particular area?
Yeah, so on the basis of 12 patient, I know we have similar experience in our past with hematological malignancies and all, but on the basis of 12 patient, a single institutional phase 2 investigator initiated 100% response. I would like to wait for a randomized study and a multi-institutional study where it actually boils down and where it actually gives us the right picture. I'm very happy with 75-85% responses also, but something 100% slightly makes this paper fancy. It is not a fancy paper, but it's slightly made it's over enthusiastic attempt. If we change our practice overnight, it's getting a plot on the moon. It's possible we may get it in next 10-12 years, but still we have to wait for the right dealer.
So answer is no. Dr. Ankur, the study drug was dostarlimab. And in metastatic colorectal cancer, Keynote 177 using single agent pembrolizumab, we all have used and we have seen its successes. Why do you think investigator didn't choose pembrolizumab? And while I was talking to about this, today morning I saw in nccn.gov, there is a trial registered already with pembrolizumab in the similar setting.
Yeah, so I don't have a real answer to it. Why dostarlimab was taken, why Pembro, Nivo, Atizo, Durva was not taken. The concept is PDL1, PD1, PDL2 binding, and to break that milieu of the tumor microenvironment. I personally feel that any of this drug would have wonders in this super selected patients.
Okay, you use the word super selected. So let's come to that super selected. It is a very interesting. And in fact, today morning, I took out 4 of my MSI high patients who also had PDL1. And 3 out of 4 had PDL1 positive, 1 had PDL1 negative, and out of 3 who were positive, 1 had 1%, 2 had around 10 to 15%. This is what I saw that both were there. In this trial, all MSI high patients, all 14 patients had very high TMB. 88 was one of the lowest, and all 14 had BRAF V600E mutation negative. You will talk about PTL1 also, Ankur, but do you think this is a coincidence or a super selection bias?
This is a I would say one class has 12 students and everybody has secured 100%. The teacher is good, the classroom is good, the school, college, university is so good. So all have variable PDL1 positivity. All were MSI high or MMR deficient. All had a very huge TMB. We have seen TMB's data. I say TMB more than 15-20 mutes per megabase is high, but this paper has TMB of 35-60. They have given characteristic of each patient and locally advanced, and more even everybody is 0 to 1. 75% of the population is PS1. Zero is, so they are very fit, highly selected, phenotypically and genotypically very conducive to IO. And so I say this is super selective group of patients, which we hardly get in our patients. We will not get moved.
Absolutely.
In our whole 1 year of practice, we will not get such 12 patients.
So, they are focusing on MSI high, but this was one observation I think we both saw, that everything was as if, like you said, gold medal milne ki tayari chal rahi thi karke. But again, we don't know, how we go forward. Uh, One of the important one, as you mentioned, is percentage of patients with complete clinical response was 100%. Some of them were rapid responders. But do you think that 6 months of dostarlimab, instead of 2-3 months of neoadjuvant chemotherapy, what we normally see, the 9 cycles of dostarlimab made a difference in these patients?
This is the most difficult question, I would say. So what is the ideal number of cycles? What is the ideal number of dose? What frequent interval is still not that much clear. So what happens is the memory lymphocytes. It's the memory lymphocyte which works when IO is being given. And many of us have patients who have taken just 3-4 doses of Keytruda or nivolumab, but they have stopped it because of various reasons, but still they are continuing that CR thing or very good partial response or a PR thing. So that 3 months or 6 months of dostarlimab, I seriously don't know if they have interacted well between that bridge of PDL1 and PDL1 to efficiently, and these were the patients who were efficiently got that blockage. So I think 3 months or 6 months, we have to wait for another, group of patients, what was the right interval and what was the
Yeah,
right
see,
dose.
I'll tell you why. Because there are 5 patients who, at the end of 3 months, out of 12 patients, had endoscopic remission, but only 2 patients had radiological remission at the end of 3 months. So between 3 and 6 months, the difference was there. And I feel that is one of the reason, if we pick up Pembro or Nivo, probably if we have the patients to wait for 6 months, I have a personal feeling that probably we will see similar type of
Yes,
result.
yes. At times, we have seen in our IO practice that the responses come little bit late. Few of the patient respond may come in second, third cycle, but few of the patient response comes in fifth, sixth, and that is why the PERSIS and IRISIS criteria have that modification. So I think it's a good idea, even if it is we see in enzalutamide or abiraterone practice that the PSA and the lymph nodal status does not match always. So we have to wait, and I think it's worthwhile waiting for another 4 to 6 months or beyond 3 months to see a good sustainable response.
Dr. Ankur, what is your take on gut microbiome? Because that is something which immunotherapy and gut microbiome success is like becoming synonymous. Dr. Purvish Parikh had given one plenary session on gut microbiome. I remember both of us were there.
I still remember that he explaining that how a cesarean section and how a normal vaginal delivery can change the future of a person when it comes to gut microbiome. Yes, it has been studied very well, but which is that right antigen in that gut, the stool area, the microbiome area, and which stimulates. And there have been papers, I was just reading yesterday, preparation of this interview, there were many papers in literature which have correlated even the occurrence of Lynch syndrome. If the
Right.
gut microbe has been so much there, and the occurrence of Lynch and the conversion of that genotypically Lynch syndrome to a phenotypically occurrence of many cancers. So there are papers on that, but yes, gut will remain.
This reminds me of my grandfather, who always used to say कि सब कुछ पेट से ही शुरू होता है.
Yes, yes.
So I think that's where we are coming to. Ankur, the last few points, and you have to be very crystal clear in answering
Yes.
those. Okay. Today, if you have such super selected patients whose TMB is high, PTL1 is positive, MSI is high, the 2 loss of expression is there, MLH1 is included in them, BRAF mutation is negative, 49-year-old corporate guy who can afford anything what you offer. He says, for me, job is the life-saving. I cannot afford to have a colostomy. I cannot afford to have a radiation. I am okay with this dostarlimab study. I don't care for any NCCN guidelines. would you give tomorrow or day after tomorrow these patients dostarlimab?
Yes, I think Dr. Parikh has taught us very well in last 15 years how to document such patient, how to legally document each and every point, whatever you're doing. If you're going beyond the guidelines, even if you're going with the guidelines, documentation is must. If I'm able to convince the patient or patient is able to convince me, it's a mutual convincement that with 12 patients with a huge response rate, 100% response rate, he doesn't want radiotherapy, he doesn't want colostomy at any cost, and he is willing to give me in writing. And what I have learned from you, Amish, is multidisciplinary tumor or special tumor board where 2-3 medical oncologists, one surgeon and one radiation oncologist can split specially with the patient and spend 45-60 minutes with documentation, probably a video recording. I would say yes to this drug. Why not?
Wow. So we started with we will wait for 6 months, and now we have come to that the data is compelling enough to
You're
give a
giving
lease
me
of good quality of life.
yes,
I know, I
yes.
feel
Beyond that super selection, I have to. Everybody has to do personalized precision
correct.
oncology.
Absolutely.
Yes. So that is a part of personalization of precision oncology.
I completely agree. So, Dr. Ankur, if a patient comes to you, everything documented, medical legally, watertight, patient says, "Sir, dostarlimab 1.5 crore, pembrolizumab सस्ता है, nivolumab सस्ता है." Will you replace in such patients other IO with dostarlimab?
I have already done that in my practice. I have
Okay.
already done. I have with the PAP and Nivo and Pembro cost and Nivo again 1+1. I have done it multiple number
No,
of
there are
times.
other tumor types. In this rectal, would you do localized rectal cancer?
So super, and now you are being very super selective. I would again discuss with the patient if the cost comes in between. So you are deviating, Dr. Amish. You are one saying that he is willing for everything, and now you are for few penny. I won't be.
1.5 CR versus the 20 lakhs is a difference here.
So I would leave it to that moment. What
Okay.
that I will leave it to that moment and that
You would be
understanding
more
between you.
comfortable with dostarlimab only,
Yes,
if
at this
possible.
point of time. Yeah.
Okay. The last question. Assuming a patient of stage 2 pancreatic cancer comes to you, highly super selective gold medalist, and he says that, sir, Whipples to main na karao. Dostarlimab hai, rectal cancer mein hai, I'm ready to afford that. Would you offer dostarlimab today in pancreatic cancer stage 2?
It is like that patient is saying in diesel car put petrol. I will not deviate that much from science is still big for me. So if there's no attempt of such treatment, if T2 Whipple is being done and Whipple knock around, so I would rather shy from that patient. I mean, I would like rather to counsel that patient more and again counsel. If he's not understanding, then we will. I don't know this answer, but this is very less happened with me. I don't think I will not also offer dostarlimab to this patient, and not even Pembro or Nivo. Even if it is high, I would like to counsel him for a good surgery.
So if I understand, you are ready to make an exception in your practice based on the super selective inclusion criteria of the patients today after documentation. As a general rule, you would wait for some time before the much more data comes. But if a patient is right in front of you, right choice, right selection, you would not shy away in localized rectal
Yes,
cancer.
right understanding, mutually understanding. I will not shy from this.
Thank you so much, Ankur. This was an amazing insight, very lively discussion as always with you. You have to stay back because you are also one of the panelists. And over to Parikh sir for this. Thank you so much.
Thank you so much, Dr.
Thank you very much, Dr. Ankur. Thank you very much, Dr. Amish. It is very obvious that you are really close friends because of the banter with which genuine and real science has been discussed so well. And as I read the comments on the chat box, people are very happy with the clarity that you have provided, especially when the questions were moving beyond the data that is present. Uh, Now we move on to the next part of the program, and that is the panel discussion. We have none other than Dr. Randeep Singh, senior medical oncologist from Delhi and Gurgaon area, who's going to moderate. And his panelists are Dr. T.P. Sahu from Bhopal, Dr. Avnish Saklani from Mumbai, Dr. Salin Chaudhary Bala from Hyderabad, Dr. Virat Lavingya from Ahmedabad, Dr. Prasad Narayanan from Bangalore, and Dr. Vivek Agarwal from Kolkata. So you can see we have pretty much covered the whole of India for this very important discussion. With these words, may I pass on to Dr. Randeep to start the panel discussion, please.
Thank you, Purvish sir, and thank you, Amish, and thanks, Ankur, for setting the stage. Ankur's name is not there, but definitely I will take comments from him. I will just share my slide. Okay. So are the slides visible? Audio, video is okay? Yes, Dr. Amish?
Yes, sir.
Okay, fine. So I think we have the panelists. So it was very exciting when I got the message. I was not in India. Dr. Amish suddenly told me, will you do this topic? And I said, yes. The reason is about the noise, which sometimes science makes in media. And this is a typical example. I was really thrilled to see how much noise these 12 patients have made. I don't know whether it has done a service or disservice to immunotherapy in medical oncology. I think it has done a service, at least for those patients, not in this indication, but at least for others who shy away from immunotherapy, and it will open a whole field of immunotherapy in operative cancers. The one which is leading is, we all know, is lung cancer. So we will start with this. So we will straight away start. I think we know our panelists. They are all medical oncologists, except one surgeon holding the fort against 5 medical oncologists, Dr. Saklani. And I think definitely he is enough to hold the fort against them. So I have put it stage 3 rectal cancer, but we can discuss stage 2. We will divide the presentation 10-15 minutes of what we can do today, and then another 15 minutes of how this paper has been disruptive in thinking. So I have taken stage 3 because this paper has 96% node positive patients. So it's predominantly a stage 3 rectal cancer for the dostarlimab. So we can start with the first Dr. Viraj and then Dr. Saklani purposely. I have put some slides, and I think we all know this screen is from the ESMO, which divides very beautifully based on the rectal MRI T3 ABCD, as well as the Europeans treat their rectal cancers very differently from Americans as well as from the other world. So Viraj, your comments, stage 3, let us make it simple. Stage 3 rectal cancer, and then stage 2 also.
So what I do in my practice, 3 scenarios where I do TNT approach. One is T3 C and D or T4s. That's one. Number 2, if circumferential.
N0, Viraj, N0, T4, N0.
Any N. So second is T4. That means circumferential resection margin is involved. And third is extramural vascular invasion. So these 3 patients would always go for TNT in my center. There are few patients who are stage 2 or even stage 1 who are very ultra low lying and want to avoid stoma at any cost. These are the patients also who go for TNT, knowing the risk that they might be overtreated. But if they achieve a CCR, they might avoid a stoma. So this is what we practice here in my center.
No one goes for surgery. That's why I said the Europeans treat it a bit differently, and it is in front of you, this table of 2018.
Yeah.
And then there are 2 questions. Do you really treat them differently when it is upper rectum versus lower rectum? And do you treat them separately when the aim is organ preservation and when the aim is not organ preservation?
Absolutely. So upper rectum, we don't even do any neoadjuvant therapy. We treat it like colon cancer. They go for upfront resection. And for ultra low lying tumors where APR is the treatment by surgeons, even T2 and 0, we have done TNT in hope of getting a CCR and hence avoiding the stoma.
No, so the aim is avoiding the stoma or following the Oprah strategy and avoiding surgery altogether, that you are giving a T3 and 0 total neoadjuvant therapy.
Correct. So higher the chance of CCR, higher the, it's a stoma-free aim. So we want to prevent the stoma. So higher the chance of getting CCR, I can do wait and watch approach.
Okay, so I will come to that whether we can actually avoid the stoma by giving TNT versus CTRT. And I think we can't do that. Dr. Saklani knows, and the paper also of both the Prodigy and others showed that the R0, R1 resection were more or less same in both Prodigy as well as the other paper. The difference was only in PathCRs and PFS. Absolutely similar overall survival. I have that slide. I can put it for you.
So they didn't allow wait and watch strategy in Rapido and
no, wait and watch is separate. Yes, so wait and watch is separate. Exactly. But if you see the differences only in pathological CR and DFS, can I, there's a lot of background noise. Someone's kid is okay. So the difference is actually only in DFS and path CR. If you see, the difference is not much. Overall survival, we all know the difference is not there. Local recurrences difference is not there, and R0 R1 resections, if you read the full text, they were absolutely similar. So I will thank you, Viraj, for your comments. We will come back to you. And Dr. Saklani, your comment. How do we do it in TMH, and what is your perspective? I think you know the points. You know the MDT discussions we were discussing. Yes, sir.
That's very good. I think I'm a surgeon in a medical oncology conference, so I'm a bit biased. I think what we normally do, we also have to look at the additional rows of boost as well. So what for standard, the stage 3, with 3A, normally we can operate upfront. We would normally give neoadjuvant therapy. We normally give chemoradiation. We also have a trial of statin along with that to increase the complete response rate to 25%. Or we can have an alternate approach of the Rapido one short course and only 4 cycles, the one, the Bujko protocol. So whole idea mainly for low rectal cancers, we are looking at complete response rate so you can avoid permanent stoma. And we also use brachy boost as well. We don't use induction chemotherapy because the result of OPRA by Garcia Aguilar has shown that consolidation chemotherapy is better than that. So we use either long course chemoradiation alone with added boost. You know the result of OPERA, OPERA with boost and brachy, you can have complete response rate of 60%. So we either give only CTR, or we give short course RT and 4 cycles chemotherapy. All low rectal cancers will also receive brachy boost. For lateral pelvic nodes, we'll also have SIB boost as well to avoid lateral pelvic node dissection. I think for all the TNT trials, the aim of all this treatment is to improve overall survival. And none of the treatments have actually improved overall survival. There's the disease-related treatment failure of 7.5%, or progression-free survival or disease-free survival of 7.5%. For this, would you give additional chemotherapy to 92%? I'm not very sure about it. Also, the role of adjuvant chemotherapy after chemoradiation surgery is not really there. In fact, with Rapido, half the people did not receive adjuvant chemotherapy. Sorry, I'm feeling like a surgeon. I really like the TNT thing, but not for everyone, I believe. So, I know your take on it.
So the brachy boost which you give it in the institute is with short course RT as well as CTRT, or it is only with?
So we are mainly giving it for long course. All the opera was there for long course, but now we have started giving it with short course, but the experience is limited. We have a good radiation oncologist for this. So induction chemotherapy for TNT, no. Short course and consolidation chemo, yes, the outcomes are good. But we've looked at functional outcomes of short course RT and chemo versus long course, and we found most of our patients are young males, and lower anterior resection syndromes are high after short course. So we have to look at a lot of things. So just for disease-related treatment failure, should we give short course and chemo? So there's a lot to be done. There's so much to be done in the country with so many advanced cancers. You guys, and this, if you look at your paper from today, that looks really good because you want the tumor to go away without any side effects, and the PDL blockade looks awesome.
Actually, when I was going through this paper, Dr. Saklani, I was actually thinking, we have not come to the terms how we place TNT, and this is again a bomb which has come, and that's why I said a disruptive thinking, that we are still debating who goes for TNT, who doesn't go for DNT. So if I can ask you, who will absolutely go for a TNT? And of course, your TNT is a short course RT with the 4 cycles of Folfox or Capox.
I think if you ask me the high risk, go on. With the high
what
risk,
is that high risk?
If you look at, people who are not going to respond, why waste time? Like Signature, PDAC, they are definitely going to fail systemically. So I think that, and they're going to have complications. So that would go for it. And if you had a high volume of nodal disease or lateral pelvic node, so they would definitely go for that.
Okay, fine. Any comment from any other panelist? Ankur, Sahu, before we proceed further.
Rightly said
Yes,
that signet ring, mucinous, and so these patients should be treated with caution, that because they will not respond that much to chemotherapy, we might, I would not use word waste, but we might lose that local control opportunity. So we have to be with our pathologist. So moderately differentiated adenocarcinoma with no signet and no mucinous component would be the right candidate if I have to pick up the pathology part.
Okay, so Sahu is there?
Yeah, I'm there.
Okay, Sahu, I was missing you. That's it. That's nothing. So I thought whether you're there or not, we will Okay, so I think Vivek and Stalin, Vivek and Stalin, you can be very crisp. So you believe in
Yeah.
TNT, yes or no? And I
So,
have practically the pros and cons which Dr. Saklani and Dr. Viraj has brought, and these are the pros and cons.
yeah, so I think, with the data coming in, we are all moving towards TNT. TNT is something that we have already started practice. Younger patients, we go with the Prodige, who are more fit and who are able to tolerate FOLFIRINOX, and a bit elderly patients where there is question of, tolerance, we go with the Rapido. But I think one of the most important questions that we need to ask here is that how much of MSI do we do in the locally advanced setting, and what is the actual data in the MSI subset of all these patients. And if you look at the Foxtrot data, what I would want to say is that the response rate to chemotherapy in MSI high localized rectal cancer, so it is very poor. It is around 5%, and there is another data from MSKCC where they have shown that on FOLFOX there is almost nearly 30% patients of MSI high who progress. So MSI high patients, definitely they do not do well in with chemotherapy, and I think this is one question that we need to answer, because the regular TNT is not something that is going to work in MSI high patients.
Okay, Vivek, I will ask you a question. Tomorrow you have an MSI high, locally advanced rectal cancer, node positive, lateral pelvic nodes, lower 1/3 of rectum involved, T4, N1, M0, or T4A, N2, M0, MSI high. Forget about dostarlimab, forget about Pembro. Patient is, will you give CTRT followed by surgery? Will you give TNT, or because he is MSI high, will not give TNT?
So I think that is what the question really is, that the guidelines currently do not suggest a different management for MSI high localized rectal cancers. We are all following guidelines, so I will have to go with the Prodige or the Rapido. But then again, this whole study has brought in this new perspective that we all need to look into, because if you go with the traditional strategy in the MSI high subset, whatever data we have regarding the highs, MSI high subset from the different trials, it is the outcomes are suboptimal. So
Yes,
we need to redefine this.
Okay, Stalin, your comments, and Dr. Amish, can I request you to remind me 15 minutes prior when the 15 minutes are left, so that we are sticking to time, Dr. Amish.
Yeah, sure. Kashish, can I request you to do that, please?
Anyone, yes. Okay.
Yeah, so this is Stalin. So do you believe in TNT? One single word answer is yes. So for whom? For the in the subgrouping you have shown according to the ESMO, for the bad and ugly tumors, definitely we follow the approach of TNT, and I believe in TNT for those. Not for those subsets which are early and immediate risk group. So for those I'm not practicing. If at all needed, only CTRT followed by surgery. If at all needed, adjuvant chemotherapy. For bad and ugly tumors, definitely TNT. So in my practice, I will follow.
One quick question, just a yes and no, no explanation. Do you believe in TNT in a MSI high locally advanced rectal cancer? Yes or no?
No.
Maybe we have two options, yes or no?
No.
No. Okay, great. So I think we got a couple of messages, and this is actually very important. I will ask Dr. Prasad and Dr. Sahu, because this becomes important also when we come to our study of dostarlimab, and Dr. Saklani has very beautifully addressed these questions. What is the sequence you follow? Whether you will follow chemo radiation followed by chemo followed by surgery, whether you will follow chemo followed by chemo radiation, or it will be a sandwich approach of 3 FOLFIRINOX followed by CTRT and then FOLFOX, and of course a long or short course RT, because most of us have been practicing long course CTRT. But yes, short course has a role, as Dr. Saklani said, and we all believe, yes, I also believe that short course has a role in rectal cancer. Dr. Prasad and Dr. Sahu then. And we all know the Rapido and Prodige. Dr. Prasad.
Yeah, so
what will be your choice?
That there is one sequencing which is a standard treatment in TNT. So it depends upon institution to institution practice, and based on certain characteristics, we sometimes feel that, I mean, there is no evidence to say this, that like if it is a node positive patients for which we are doing a TNT, we intend to start with there's a tendency to start with the induction chemotherapy, because distant failure is what we assume in this patient. Or if the intent is to preserve the sphincter and try to get a complete response, then a long course radiation to start with, and then incorporate the chemotherapy with that. And the data actually which says that the preservation or the effect is seen more when you actually delay the after the radiation, when you give more time with more chemotherapy. So there is the data to say that the more time you get after radiation, you get more effect. So I don't have a one particular answer to say this is the best treatment for all patients who we choose TNT. I think we have to choose about based on, as we all discussed before, the multidisciplinary team. I don't think this decision is taken without taking care of all the factors. Let us see what Sahu has to say.
Okay, Prasad, the data which you are talking about, Sahu, sorry I will just take a minute. The data which you are talking about is this randomized phase 2 trial. It has 306 patients. And I think this is what the TMH people do follow, is that when you have, what you said is, when you have a CTRT arm followed by consolidation, the chances of achieving pathological CR are 7% more. And when we talk about clinical CR, they will be much more, and thus organ preservation and other things becomes much more important. And that is why I think most of them is consolidation chemotherapy for maybe this is one of the major data set which said Dr. Saklani to make this statement that induction chemo no. Dr. Sahu, your comments.
Yeah, I feel if someone,
and yes, sorry Sahu, you may comment about this also, that if I am following a consolidation chemo, then what will be your RT choice, because that becomes very important, whether it will be a rapido based CTRT or whether it is a classical CTRT.
Yeah, I was coming to that. So I feel the question is, if you are following a short course RT and institute is believing in that, then you need to follow it up with a consolidation chemotherapy. You need to give that 3 months of gap, because the chances of getting the path CR is much higher if you just give that option. So if someone follows the short course RT, it should be a short course RT followed by a consolidation chemotherapy, then assess and then do the surgery. If someone is doing a long standard course radiotherapy of 28 days, let's say, then I think the starting off with the chemotherapy like the FOLFIRINOX and then going for it 28 days, because after that you are anyway going to give a gap of 4 to 6 weeks. I think that is what really is the difference between the Prodige and the Rapido. I think that is what we should remember. I would not be comfortable doing a chemo, doing a short course, and then just operating after that. If I give a short course, then I would do a consolidation chemotherapy. If I do a standard course radiotherapy, I would be comfortable with the neoadjuvant chemo, then consolidate with the CTRT, then assess the response.
So long course CTRT followed by consolidation, no for Sahu.
Not no exactly, but the purpose is not there. If you are doing a short course and you just want to operate before that, I think you are going to get lesser
long
of
course CTRT. No, Sahu, long course CTRT followed by 4 cycles of FOLFOX. You may, but I would be more comfortable going for a neoadjuvant chemotherapy followed by a long course CTRT. Okay, fine. So I think we will just cut. This is the last question. Then we go to the paper, and this was necessary because that puts everything in perspective about dostarlimab. Dr. Saklani, sir, in your practice, how many patients you offer for organ preservation and how many opt for? So say suppose 100 patients you have seen in a month of locally advanced rectal cancer, dostarlimab is not available. So how many are you currently offering, and how many opt
for all low rectals, we already tell them either if they're in the statin plus long course chemo or with any of the thing boost therapy, that if they have complete response, they will be on the wait and watch protocol. Almost all of them opt for organ preservation because they want sphincter preservation. We don't offer it for upper rectal cancer because surveillance is a problem. So anything which can't be felt with finger, even if they have complete response, we offer surgery for them. So most people will avoid a permanent stoma and they will act for this. Only people who don't accept it are actually doctors. Doctors are the only people who are not actually accepting wait and watch approach. We tell them for wait and watch approach on follow-up, there'll be a 20% local regrowth rate with 90% salvage rate. There can also be a 10% metastatic rate on this. So most people are happy from the things, and we have almost 60-70 patients who are on wait and watch protocol. In fact, on every clinic, we see 4 patients on wait and watch. But we don't offer it for higher tumor because that is a main problem. So that is good. So I think we also have to see the induced complete response versus a normal complete response. I mean, the survival has not improved despite this being there. So the outcomes of induced complete response may not be the same as original complete response. So that is one of the things. The whole idea was to have more complete response, so survival we can improve. But survival has not changed. So only thing we have changed the endpoints to say that complete response is more, but overall survival not really. So okay, but I would say people are opting for it quite often, except for doctors.
Okay, great, Dr. Avinash. That was actually, I mean, a very important statement, because that puts this trial absolutely spot on, that you will be offering it to. And what about mid-rectum? Upper rectum, no.
Mid-rectum, I think
yes.
if they are young patient, we offer them TMA. We have high volume complications or lateness. We explain to them about LAR and things like that, and then most of the times we would offer them TMA.
And as you have started offering organ preservation, is it that the medical oncology unit in the GIDMG is coping up and giving more and more TNTs and CRs to you, and you feel that is working?
No, I think we are offering weight and both with short course RT and chemo and with standard chemo radiation. So at present, we are not giving TNT to everyone, because we are not sure whether it is that cost effective, but that's a part of a trial for PDSC and Singh, and that will come. That is, as soon as it gets approved, we'll get it on.
Okay, thank you, Dr. Avinash. So this is, I think we have summarized very well how we are treating rectal cancer. And now this is what happened in the middle of June or in the first week of June. And everything was, I mean, this is a disruptive thinking that what we have discussed till now is slightly different now. And let's presume that dostarlimab will be available in a year. Stalin, will you check MSI in NACT setting? I think Ankur very rightly said that.
Till now, no, sir. But after this data, definitely I will be checking in majority of the patients.
Sorry, Stalin, just a minute. There is background. Okay, fine. Stalin, can I have your comment again?
Till now, I'm not checking for all patients. But from now onwards, I think I will be checking for all patients of in the localized and local advanced rectal cancers.
Can I request the others to be please on mute? There is a background noise. Can you please check
that
your
noise
mic?
is at
I think Stalin's
That's
background
at his
noise.
end only, sir.
Achha, okay. Sorry, Stalin. Sorry, we have taken your comment. Okay. So we come back to Sahu. First Sahu, then Prasad. Sahu is the best person to dissect the trial, though there is nothing much to dissect here, because the patients are only 12 and 16. But yes, still they are important because we have some decisions made on this. Sahu, primary endpoint, sample size, follow-up duration, and what do you think is the ideal endpoint for such type of clinical trial?
Yeah, I think the sample size, they never, although they had a criteria that if more than 11 patients did fulfill the CR criteria, they would be telling this trial to be okay. But I think the sample size is too short. My main problem has been with the second point. The results were out too early. If you look at the endpoint, it was a clinical response at 1 year. That was the endpoint for the trial. And if you look at this text, there was only 4 patients out of the subset who had completed 1 year. I have an issue with that. A trial getting matured enough with 1/3 of the patients who were to be analyzed, and we come up with the results and the media goes haywire and we are also so excited and we want to change practice, I would not do that. I would wait for at least all the patients, because this is something of a curable cancer. And I'm telling them not to do anything after my 6 months of my immunotherapy. So that is something I should be pretty sure about. So that is point number 2, which I wanted to make. What would be my primary endpoint? If you ask me, my primary endpoint would be in such a trial to be, I would love to see in the end of 3 to 4 years, because if you look at the metastatic immunotherapy trials, around 2.5 months, 1/3 of the patient lose their responses in MSI high. So I would expect that to happen.
2.5 months or year?
No, 2.5 years.
2.5 years. Okay.
Approximately 24 to 30 months is where you 30% or 35% lose the responses in the metastatic setting. So we should use that yardstick at least to look into, and I would be comfortable when the follow-up for 3 years come in, and then you will be pretty sure to be confident telling that. Last thing, we are forgetting that these patients who are on follow-up, one thing that strikes me is that the amount of PET scans and the endoscopy and the biopsies they have to go through, are we willing to do it? I can do a parallel with the CML, the TFR. It is very easy to tell that I would practice TFR, but I have seen doing 3 up on my patient are lost to follow. So that is something that you need to do this 3 monthly for the first 3 times, then once in 4 months, probably for life. And is that a easy way to do a PET scan, endoscopy, and a biopsy every time you do endoscopy? That is something I would know. I would love to see others, because I am happy about it. There's something that I can offer, but will I change my practice?
Okay.
I will be not as confident
Fine.
as the expert today told.
We will come to that question. If you answer that, my last 2 slides will get wasted. That they are there for your last opinion, last carry home message. But Sahu, what if you would have been the PI of this trial? What will be your endpoint? Are you happy with ORR? Are you happy with PATH CR? Are you happy with clinical CR? Or you are happy with PFS? I think that is very important. Suppose it's a multicentric trial. You try to run it in India. Dr. Saklani has patients. Ankur, we all give you patients. What will be your endpoint? Follow-up, you have told. Median follow-up 3 years.
PATH CR will be my first endpoint. The only thing for PATH CR, you have to operate. That's probably the drawback. So basic thing, the thing which has attracted everyone will go away from this. The second point which I would love to have done is at the end of 3 years or 4 years, little bit longer time. 1 year for me is a very short time. I would love to see the patients who are relapsing and are failing and requiring a retreatment. That probably would be my 2 points, and I would have taken the cue from the metastatic setting.
Okay, so Dr. Saklani, are you doing PET-CT, and is PET-CT a protocol in the follow-up trials? I feel, can you give us a very short comment? Do you do PET-CT in all, and is it a protocol for organ preservation?
No, I think we just do CT scan, CT chest at the pelvis. We don't do PET scan actually. So we didn't find any difference between CT and PET when we looked at it individually.
But you do an extra pelvic investigation, extra pelvic imaging every 3 monthly.
If you're doing wait and watch, then every 6 monthly they would have it, and 3 monthly MRI they would have it.
So
3 monthly MRI.
Exactly, that's it. PET CT is much cheaper than CT scan. What combined together?
Okay. Dr. Prasad, sorry, your comments. The same question, and whatever Sahu has said, do you concur or you have a different?
Yeah, I concur with Sahu, because we all have the same discussion on this trial. But his comments that the usual progression which happens, I think the duration of treatment here is only 6 months. So getting an evaluation at 12 months is reasonably okay for this, is what I feel. To say that but the number of patients who reached that were only 4. So maybe another 6 months of data would have given us some more information, because the blockbuster part of it is the 100%, right? So when you have to say that 100%, when you have only data on 1/3 of the patients, then it is slightly, I agree with him. And the other point that I don't think that the PATH CR would have been my endpoint if I was to design this trial, because the main attraction or what we are looking at here is whether we can avoid surgery in these patients. Because this is a very high, super selected group of patients who have ticked all the boxes for immunotherapy. And if they have to undergo surgery for then it takes away the main objective of trying something like this.
I think Ankur has the point. Yes, Ankur.
I think I totally agree with Dr. Sahu, and we have good 3-4 examples when fast track approval was given by FDA and it has been withdrawn from the same FDA, and we stand nowhere. We have seen with our hepatocellular patients who were responding to nivolumab, and now there's a withdrawal from the FDA. So long-term follow-up should be done for all these 12 by 12 patients, and my goal would be pathological CR, where you go for surgery and document there's nothing, no tumor left behind.
Okay, fine. I think I will proceed
Can I
further.
make a small point here, Randeep? And
yes,
you may
there is some controversy, because when I was hearing Dr. Saklani, if he would have been the PI of this trial, he will not operate even a single patient. So the point of PATH CR may not come, but I will just leave it there because we have to cover some more topics. But Sahu, I will take your
15 minutes left, sir.
Yeah, just a small thing.
Okay, thank you, Kashish.
If you look at the IO trial of the Niche, I hope I got the name right. And you find that there were 20 patients and 20 of the 20 had a PATH CR. So why has that not attracted so much of traction? And why is this, although that is a much larger subset, and that is the same 100%, and you have documented PATH CR?
Okay, fine. Point well taken. As I said, I will have to proceed further because of the time limits, but thank you for your comment. We will go to Viraj and then Vivek. Are you happy with the rapidity of response? I mean, are you excited? I will say you have to be happy with the rapidity. I will just go back. There is a rapidity of response, and at 6 months, couple of them achieving CR. Are you excited with that? Because you may not be able to achieve that with CTRT followed by 4 consolidation. And I think we have covered this, but you can give your Viraj very brief comments about follow-up of organ preservation trial. Or Vivek, you can give the Viraj, you can give the response rapidity comments. Both of you can give a brief comment on these two topics. Sorry for the confusion. Please.
So yeah, I am pretty much convinced about this strategy of using checkpoint blockade for MSI high rectal tumors. One important point which was missing throughout the last 1 hour of discussion was role of TMB. TMB, if you see in all the patients, was more than 37. We have two important papers from a metastatic setting, that patients who have high MSI but low TMB, in the range of 10 to 20, they don't do well with MSI. So it's just matter of time when they enroll 50 patients. I'm sure there will be some patients who will not be high TMB. These are the patients who are going to fall on their face. So that 100% what Dr. Prasad was saying is kind of misleading. But I think is if I am going to use it, and I have personally burnt my fingers in 3 patients, jumped out of my chair, MSI, and right hyperprogression in 2 months. So these were the patients, and I'm doing one research on these blocks, that these are the patients who are TMB low. And I would also want Dr. Ankur to help me on this, since he said he has 8 patients of MSI high treated with checkpoint blockade. If you have any of those 8 not responding, I want that FFP block, because I'm doing whole exome sequencing on them. Anyway, so I am excited if MSI high.
Okay, Vivek, your comments about the rapidity of response and the difficulty of following for an organ preservation with an endoscopy, DRE, MRI, PET CT, your experience.
Sir, I think
you are mute. Vivek, you went on mute. Yes, please go. Please give the Vivek some problem with your. I can hear you now. Please go.
Yeah, so I think, sir, we all very convinced with the rapidity of the response. We can clearly see there. And then if you are going with the organ preservation technique, you have to sort of follow this protocol of very, very, strict surveillance. And in our pool of patients, we have never tried this, except one very elderly patients who are not willing. But then again, you have these problems of surveillance in our patient. But one point that I would want to make out here is that this is a very highly selective subgroup of patient, and there also we do not have the NGS data yet as what was the KRAS, NRAS mutation and what was the BRAF mutation status of all these 18 patients. Now, if you look at the
metastasis, it's there. Vivek, it's there.
BRAF has to be negative.
But KRAS, I think KRAS and NRAS is not there, sir.
No,
and if you look, and if you look at the keynote 177 paper, where you have pembrolizumab in the metastatic setting, you notice that it is the KRAS NRAS mutated subset where the MSI in the MSI high subtype where pembrolizumab did not work, and that was the only subgroup where we can see the response not there. Also, you have to see that in the metastatic setting in the pembrolizumab paper, we had 30% patients who actually had progression on pembrolizumab upfront, whereas here you see all 100% responding. So I want to know what is it. It looks to me that probably in a localized setting the disease is biologically less aggressive. In the metastatic setting probably it is more aggressive. But I think KRAS NRAS mutation type, that is definitely something you want to know before you want to sort of subject all your patients to immunotherapy. But this is a novel idea and we should look at it, because probably this is going to give you better results as to what is the current standard for MSI high.
I think
Randeep, 8 to 10 minutes more.
Yes, only these we will be able to cover it, Dr. Amish. Of course, we will be able to cover it. I think both Viraj and Vivek brought very important point. I mean, the media and we all oncologists are going gaga over MSI high, but it is not only MSI high. Viraj said very rightly, they are very, very high TMB. One of the patient has a TMB of 100 megapase. I mean, 100. I have never seen it in any report more than 70, 80 in my practice. Second, as Vivek said, we don't know about the KRAS, NRAS, BRAF, we know it is negative, and other mutations also, how they are playing, we don't know. Many other things. Apart from the MSI, we know right now, but let's see how many of these are Lynch, how many of these are I mean, the MSI high can be a Lynch, non-Lynch, we know that also. One more question to Viraj and Vivek, and very quickly, if you can answer.
Randeep, Amish here. Randeep,
Yes, Dr. Amish, please go ahead.
Yeah, what we had, so far in last 7-8 minutes, what we have discussed is hypothetical situations. I think what we need to
Dr.
see
Amish,
is that if we have patients with MSI high TMB, high PDL1, KRAS wild type, BRAF wild type, what do
Perfect,
we
yes.
do? I think, rather than focusing on what will we do, rather than, we say in this super selective patients, what will we do?
So I think with this available data,
just hold on. I will come to that. Sorry,
Yeah.
sir. I will come to that. That is my slide actually. That is the last slide where they have to summarize. Dr. Amish, I will cover that in 10 minutes. That the whole 2 slides are for that. Just one quick question. Anyone can take it. When anyone extrapolate, that is Dr. Purvish wanted to know, and this is very important. Anyone would extrapolate those to Pembro, and we know this is the data
Yes.
of pembrolizumab. Yes.
Yeah, sir. So that is what
Wait,
I
yes or
also
no?
want to say. Yes, sir. I would want to, because with the existing data for MSI high, the results are suboptimal. And I expect if we don't have dostarlimab, I would at least offer a Nivo-EP combination or Pembro. I feel Nivo-EP has better data as compared to Pembro. So probably yes, because the existing data is not good.
Okay. Anyone else would like to substitute dostarlimab to pembrolizumab? Ankur, yes or no? Ankur said no, I think. Ankur said yes. Yes. Okay. Viraj, yes, no?
Yes.
And Stalin?
No.
No. Okay. Prasad?
No.
Prasad has told no.
I have told no. Yeah.
Sahu said no. Okay.
I know.
So
I will do it. I will do it.
You will do it. Sorry.
Nivo
Okay, we'll do it.
Nivo EP.
Nivo EP. Okay.
Yeah.
Fine. So I think we come to this $1 million question. What Dr. Amish wanted to know. We have this subset: MSI high, TMB high, dostarlimab available, patient affordable, all caveats, all if buts covered, patient young, patient fit, lower rectal cancer, node positive, wants organ preservation, everything fits in. So is the study clinically? So what I will do in this order, we can take yes and no, the comments, the first question, and then we can take yes, no only, no further. For the interest of time, I will request all the experts just yes and no. And the order is in front of you, starting from Sahu and ending with Dr. Vivek. Study is clinically meaningful. Yes, no. Sahu, you can start. Sahu, Viraj, Sahu. Dr. Sahu.
Yeah, maybe.
Maybe. Viraj.
Yes.
Avinash, Dr. Saklani, sir. Dr. Saklani.
Oh, sorry. Yes, definitely.
Yes. Dr. Prasad.
Yes, meaningful.
Dr. Stalin.
Yes, clinically meaningful.
Dr. Vivek. Vivek.
Yes.
Okay. Are the results practice changing? Will you do it? What Dr. Amish said. Will you do it tomorrow for this subset? Dr. Sahu?
No.
No. Dr. Viraj?
Yes.
Dr. Saklani?
I'll send it to my medical oncologist.
So that means yes. That means yes. Dr. Prasad?
No, I won't start practicing this.
No. Okay. Dr.
No.
Stalin?
Yes.
Yes. Dr. Vivek?
Yes, sir.
Okay, fine. So the last question I will answer. Yes, this is a strong scientific basis to follow this space, and we will adapt it for future use. And
Yes.
no, this I will take it yes, unanimous yes, because I have seen the yes and no from all the panelists, and I know this is unanimous yes from everyone. Dr. Amish, does that answer your question?
Yes, Randeep, you are the moderator.
Of course.
But I would like to ask you the question.
Yes, you can ask me now. Okay.
First 2 questions which you put forth after this wonderful moderation. What would you do? And my question, and I don't want an answer to the question which I'm going to ask right now. I think recall 20 patients of each of your practice who are on permanent stoma, young patient who have gone triple modality, have sexual dysfunction, urinary incontinence, and then look at these questions which we are asking. It is not about changing the practice. It is about one more option available for somebody who wants to take that. That was probably the answer which I'm looking for. But I would like to hear from you, Randeep, because you always make a reasonable and calculated judgment.
Okay, Dr. Amish. So my take is that I will not upfront offer dostarlimab. if the patient fits in the criteria of the clinical trial super selective, he has finances and he is willing to do it, then he will be the one who will be pushing me. I will wait for the data, at least a follow-up of 2 years, and I would wait for at least 50 patients till मैं आगे से बोलूंगा आप dostarlimab ले लो. For that I will hold on my guts. So
Understood.
if we, Dr. Amish, if we have time, we can take this message, or else we can close because we have covered most of things.
Now we have 2 more minutes, Randeep. You can take it.
So we can take a short message from everyone regarding locally advanced rectal cancer and this trial in perspective, and we can follow the same sequence. We can have just 1 or 2 comments. That is a carry home message for all the students and other colleagues who are around. We can start from Sahu and then the same order we can follow.
See, for me, for the high risk, what was told T3, T4 node positive, the mid and lower rectum, I think TNT is the in thing. For that's point number 1. If I follow the short course, then I would go for a constellation chemotherapy, as I told you. Otherwise, FOLFIRINOX for a young patient does good things to the PATCR thing. This I would point out in my discussion, and as you rightly point, I will never push it till I get a long-term data, because it's a curable setting. I would not change my practice so easily, and we have seen FDA changing its approval so soon. And I think the things can change very fast here. Otherwise, it's lovely and encouraging, and we should be discussing, but I will not push for it. That's the word I use.
Viraj?
I second both the points, TNT for all advanced patients and start doing MSI for all patients.
Dr. Saklani, sir?
I think my take would be MSI on all rectal cancer biopsies before starting any treatment. And the other thing, I would change my designation from colorectal robotic and immunotherapist.
From tonight onward, that was very good. So at least the 5 medical oncologists can pursue that, yes, immunotherapy is a good tag to be attached in your designation. Thank you, sir. Dr. Prasad?
Yeah, I agree with Sahu and Viraj. Nothing more to add.
Okay. Dr. Stalin?
Yeah, same. I agree with Sahu and Viraj. For the, as I told previously, for the bad and ugly tumors, definitely a TNT approach. So if I am doing a short course artery, definitely doing surgery after a period of chemotherapy, 3 to 4 months of chemotherapy. What I follow for young fit patients, always the Prodigy is what the TNT approach I follow.
Dr. Vivek?
Sir, this is already practice changing because we have already seeing patients being referred from TMH for CTRT where MSI is already being done, which was not done before. And if we are detecting MSI high patients with the existing data of the current standard, I think the results are suboptimal. And if dostarlimab is not available, I probably not be shying away for discussing other immunotherapeutic agents which are available, because I think the results may not be as good as dostarlimab, but it will be better than what is the existing results which are there.
Okay, I'm feeling jealous. Ankur is drinking something in the opaque glass. At least Dr. Saklani is wise enough to take a glass, a transparent glass, and have a drink. So I think, Ankur, I can't take your last comment. If you want to make a last comment, I mean, you have been extensively given.
I would say that
after this discussion, I mean, after all this discussion, Ankur, just one brief comment.
So from me?
Yes, Ankur, after the discussion, just one brief last comment, carry home message.
So carry on messages, take this paper as science, essence or flavor of science. It is not practice changing, but yes, it may or may not change. We have to wait for the time.
Okay. Thank you, Dr. Amish. It was lovely. And to all the experts and panelists for teaching me today how to treat locally advanced rectal cancer. Thank you.
Excellent. Parikh,
Thank
sir.
you very much. Thank you very much, Randeep. I like Dr. Sahu's comment that, this cannot be taken unless there is long-term results. And we have seen how US FDA has reversed its approval in the past. I want Dr. Raja to comment on that in his conclusion with this caveat that whatever long-term survival we have asked for or whatever reversal has happened with US FDA has never been for data which is so clear-cut. It might have been for a marginal benefit of p-value that we have seen in some instances. But I think the fact that this statistical considerations in this paper required 4 patients to benefit, and now we have got not 4 but 4 times that amount that have benefited, should be a very important scientific consideration where we decide what we do with our patients. So we have none other than Dr. T. Raja, senior medical oncologist and the hero of Apollo Hospital in Chennai, to give us the expert conclusion and the way forward. I don't want to stand between him and you. Over to you, Dr. Raja.
Thank you, sir, for your kind invite. And I must first of all thank Dr. Purvish Bhai, and then I must profusely thank Dr. Amish for inviting me here. Such an exciting series you have put through, Amish. Privileged to be part of some of that, but I listened to most of it, and you have really created an amazing track record of such extensive discussions in each of these. That's my comment to you. And then amazing interview. Dr. Ankur was spot on. And again, I also have some personal experience with Ankur, with his prolific practice. I have been impressed how modest he is, with a couple of conversations I have heard. So my hat is tipped to Ankur. Very great interview. And amazing panel discussion. I think Dr. Randeep really played a kind of the classical coach, where he would throw some soft balls and then some hard balls. I think and all the but all the panelists did it beautifully. So with that comment, allow me to just quickly summarize the context. As a clinician, what do I do? That's what bothers whenever I want to see any data. And this is the topic of what has been given today, PD-1 blockade, MMR deficient, locally advanced rectum. It's already selected. We talked about a lot of super selection here. And I'll begin with a couple of my patients. This patient I saw in 2014, transverse colon disease, surgery, and then adjuvant treatment, and then relapses in 2014. We do the usual thing, KRAS, NRAS, started on KRAS positive, bevacizumab, chemo, and then went on to be fine for some time, again relapses. Then we go for a second surgery, CRS, high-pec, liver resection, so on, and then goes to Mumbai for a surgery, comes back to us. And then again, second line chemo, bevacizumab, continue, peritoneal nodules, again bevacizumab plus IROX, every trick of the trade, tried. And this is the long history, long images going on and on. In 2018, he progressed, so we didn't know what to do. Finally, we said, okay, do NGS, and we'll see what comes out of the NGS. And this is what we found. We saw that these genomic aberrations, many of that extensive, I think that also really is, now we understand that this is a really disturbed genome. You can see many of these are really saying that this is a hypermutated disease, but we didn't understand all that at that point. But we saw that this is MSI high and TMB high, 51 mutations per micro. That's what, and this is in February 2018, and FDA had granted tissue agnostic approval for pembrolizumab in 2017. And so based on that, we put this patient, after all these multiple treatment, we put this patient on single agent pembrolizumab. He's a young man, he was at his 40, just desperation, I would say. We didn't know what to do. And these are the scans. To our stunning surprise, he showed such an excellent response. Fine, we were happy. Continued pembrolizumab, single agent, goes on and on and on and on, 40, 44, and he runs out of money. Then I convinced the company, compassionate, and they run out of compassionate program. They say that this is the universal throughout the globe. This is the compassionate program number that has been reached, doctor. We can't do anything more. So at that point, I decided to stop. He continues to be in complete radiological remission even now. So that's the proof of the concept. That was in 2017-18. This is another patient who presented recently, stomach cancer, 42-year-old female, and the loss of nuclear expression of MSH2 and MSH6, MSI high on IHC, PD-L1 is low, please see that, and HER2 and all negative. And this is what we did, checkmate 649. Look at the response. Look at the response, what we are seeing here. This is stunning, and this is beyond all sorts of question mark. Look at the response. And the patient continues to be in response. Of course, the patient is continuing. But I'll present another patient. This is a patient, pancreas, a VVIP, comes to us after much treatment and intolerance. And this is the persistent disease, obstruction. You can see a GB, which needed a full GB. There was a pio gallbladder. We had to put a puncture there, drain it. And then at that time, he was very sick. He was not fit for anything. Again, as a routine, we did this NGS, high TMB, high MSI, and he had a KRAS G12D. I said, sir, nothing much can be done. If you want, I will try immunotherapy. And that's the response with single agent immunotherapy. The previous patient was a Nivo plus chemo, and this is single agent pembrolizumab. Look at the response. And now this patient has already crossed 2 years, and we have already stopped the immunotherapy. And the patient is now on follow-up, and he's continuously, he had a CTC positivity, and then now he's continuously CTC negative. We have been following, he has already crossed 2 years. The concept is that the science is already there, as Ankur pointed out, and as Amish pointed out, the science is already there begging for us to make a sense of it. Then now look at the context. We all know locally advanced rectal cancer, and we heard the various data, debate between whether I would do a Prodigy or whether I would do the Rapido, whatever, fine. What is the available data on any of these best trials, whether you want to do the FOLFIRINOX followed by CRT, or you want to do a short course RT followed by whatever? What is the result that's available? If you look at the PAT-CR rate with Prodigy, you have only 27.8%, and with the CRT and only CRT, the Prodigy would have a 12% response, I mean, a PAT-CR rate. And this is universal across various institutes. It may be different, but in our own institute, just with plain CTRT classical, our TRG 0 PAT-CR rates, we did surgery for all of them. It was 18%. That's what we could get. And those patients are being followed up. Now, in this context, look at this trial, what they have done. Of course, often the word is used as super selected, but I would say that they thought about this idea of super selecting and then putting this into a trial. That's what I would think as a beauty. And the flow of the clinical trial has been well discussed, and the results, as the investigator would claim, is that in a CCR of 14 patients, 14 out of 14, no grade 3-4 adverse event reported, and Amish would often emotionalize this in a young man with a sexual dysfunction, so on and so forth. Perfect context, usually in young patient and the lower stage disease. That's where you will see the MSI, and those are the patients usually localized. They are not going to metastasize, and those are the patients. That's exactly the group that you will see. And chemo, radiation, surgery is not required. This is the emphasis of the investigator. That's fine. But look at all the criticism. Let's listen to the criticism. Single center study, small group, but investigator initiative. That's brilliant, I would say. Phase 2 study, single arm study, very, very important. The only thing that I would be very, very careful is that now only 6 months follow-up data is available, but one of their important endpoint is that complete response at 12 months is the objective. So that is very important. We'll keep an eye on the ball. Longer follow-up is needed. What about OS and all that is fine. And then, we know that depending on which data you read, 10% of the rectal cancer, but I think it's a metastatic that if you look at the localized population, you will have about 15 to 20% of them will have MSI high. And then why dostarlimab? Why would you choose? And how did they end up this 6 months duration? Is it sufficient? This is based on what prior data they chose this 6 months. All these are important questions. And how is it different from other PD-1 inhibitors in the market? Pembrolizumab, nivolumab, everything is a valid question. But look at this chart. This chart is, can we ever see this in any other data? If you look at this, this is just like one of the top student scoring A+, in every subject across the board, left and right on X and Y axis. You see CCR in all of these things. And then you see this most important thing, what Amish wanted to point out repeatedly, there is no grade 3, grade 4. So I would say that, again, the question that was asked is whether this is practice changing and whether this is going to be, is this science and is this convincing, etc. We'll come to that. And one more question that was sent in the original invite was that, a new era for surgery-free cure of cancer. Has it begun? That was the question that was asked by Amish. My point is, why should we worry about being surgery-free? Less surgery itself is, again, a great goal. And then capturing an elusive goal, we can be cooperative with each other. It is a step-by-step approach. We need to look at whether finally we reach the goal in the best possible way. So I think there is a lot of essence here. Now, let me just summarize what the panelists said. Clinically meaningful, 6 out of 6 said yes. And if I have to include the moderator, it is 7 out of 7. Practice changing, I think it was 4 out of 6. And scientific data, validity, and science behind it, all of them said yes. Whether it is super selected, I think that is yes. But that's again the brilliance of the investigator to have thought about it, embarked on this trial, and then hitting a jackpot. I also remember, bring it to your context, I was there in one of the ASCO meeting. I think it is in way back in 2000 early, when Brian Drucker presented his data, and John Goldman and Brian Drucker would discuss post that GLIVAC data, and John Goldman would advise everyone on the panel, say, you know very well that he is the doyen of allogenic transplant. He would say caution, caution, caution. The point is, John Goldman, he's a giant, and somebody is questioning him. But I think science stops for none. It just pushes everybody away. It's finally the truth and the science that speaks. And Parikh had already written in this that you hate it, you love it, but you can't ignore it. That again summarizes it from some other context. Maybe finally, as a clinician, one of the most important question is that maybe 12 months, it's only 6 more months. I think it's going to be practice changing. It's clinically very, very meaningful. Maybe another 6 months of caution is just judicious, but I think this is science and this is going to take over. That's my take on this. Thank you so much for this opportunity.
Is, I think, one of the most excellent, expert comment, sir. And that's why we all are fan of you, and we want to listen to you more and more, sir. I think this is superb summing up. Thank you so much. Over to Parikh, sir. Sorry for cutting into it.
No, it was great. Thank you, Amish. Thank you, Dr. Raja. As everybody has echoed what Amish said in the chat box, the summing up has been really nice, especially when you put your own patient and you really showed that when the patient has no hope, has failed multiple lines of therapy, and then all of a sudden something like a magic happens to the patient. And yes, I agree that some of us are concerned about the short follow-up and want 6 more months of follow-up. But wanting a little bit more data, a little bit more follow-up is always going to happen in the real life. And when the patient is standing in front of me today, I can't ask him to say, oh, please come after 6 months, then I will treat you. So under the current circumstances, if the patient is standing in front of me and says that I want to do that, what is it that we want to do? And all the pros and cons have been clearly highlighted and brought out first by Ankur in his interview that Amish took, then by Randeep and all the panelists who did a fantastic job, and now finally Dr. Raja. So I think Oncology Beyond the Obvious is living up to its reputation in making sure that we have such intense and free and frank discussion. And we will again continue to invite you for the next session next month on the first Tuesday of next month. With that, I thank you very much. And Amish, final word from my co-director.
Thank you, sir. I think next session, I can promise you, is going to be as lively as this one. Just watch out for the space and continue to support us. Extremely important would be some areas of improvement. All those who have attended, we would really love, so that we can keep on improving and improving. Thank you so much. And I think with sir's permission, we can wind up the session.
Right. Thank you, everybody. Thank you so much.
Thank you.
Good night, sir.
Good night. Good night.